you have to use that in combination with strengthening of the opposing muscle group in that recovery period. The additional advantage, which is really important to consider in the life of a child in school, is that soft tissue surgery has very little lag time for recovery. In our institution, the children are told that they will have to get out of bed the next day. They will have to go back to their therapy program within 2 or 3 days of the operation, so that the benefits of surgery are carried forward into the benefits with the recovery and the rehabilitation program. If you add any bony surgery to the prescription, that is not possible, because you then have to delay the recovery for a bit, which means the child may miss longer time from school and so on and so forth. So if that nuance has to be addressed, it will also need to be considered at the start.
So again, what should we do yourself?
Stretch casting can
So you would then decide. So for us, right, we would divide the severity of the knee flexion deformity into 3 kind of rough grades. And the mildest grade is the one that's between 0 and 10. Then moderate size is 10 to 20, and anything more than 20 degrees we would say is a severe, because the risk of a nerve stretch becomes very high when you get to that side. So she's in the moderate grade at the moment. So for us, the surgical prescription would be to address the hip flexion contraction with a psoas lengthening, and exactly like you said, we would release the proximal rectus at the same time, because you're right there, you have to protect the femoral nerve when you do that, but it's possible to get both hip flexor stretch and some of the rectus released at the same time. We would not do any rectus surgery distally at this point in time. For the hamstrings, we would do a medial-sided hamstring operation, and that would be an intramuscular lengthening of the gracilis, so at the muscular tendinous junction. The semimembranosus is a funny muscle. It's very, very big and flat, and it has this aponeurosis on the outside. So we would do an aponeurotic lengthening of the semimembranosus, and the semitendinosus is the biggest culprit. It is the tightest muscle, but it has an action both below the knee and at the pelvis as well. So our operation for that would be to reattach it above the knee to the at the level of the adductor tubercle, so that it maintains an effect on the hip and allows the hamstrings to continue to work as hip extensors, which they would not be able to do otherwise. For her at this age, I would stop, because the next level of surgery is looking at patellar tendon shortening with a supracondylar extension osteotomy, and I wouldn't do that in the first instance. I would do this soft tissue surgery, give her a year to 18 months with the therapist, see how much of a functional improvement she makes, make sure that she hasn't run into any risks or complications, and then decide whether any bony surgery is necessary or not. In the post-operative recovery plan, we would continue the knee splinting at night time. We would use very good solid AFOs with no surgery or intervention to the gastro to help her stand, and then see how she goes. That would be my plan.
So thank you everybody for this case. And any questions from the audience? Anything you want?
Attach semi-tape to the level of adductor tubercle.
Yeah.
So if you reattach, will it not delay your rehabilitation?
No, because it's a non-absorbable stitch, and it's a soft tissue stitch like any other. The muscle will work out its own length. The only thing is you don't lose the effect on the pelvis.
So, but in that case,
It does not delay or slow down your recovery.
So in that case, when will you plan to start the rehabilitation?
Straight away.
Second,
Absolutely.
as you said.
Because the way the stitch is done, it is stitched back to itself and to the adductor magnus tendon, which is where we would do it. We wrote it up about 10 years ago in a paper that's in the JPS. So you can look it up. And the current edition of Loveland Winter has got the operative drawings as well as for how it's done. It's a perfectly safe operation. as long as you are careful with the repair, it's got very few complications.
And one more thought, as you also said that the only surgery, she has around only 10 to 15 years, although she, as you said, she might not warrant only surgery.
Yes.
But if we don't touch the soft tissues, because that will cause further weakening of the antagonist muscle, the sensors and other muscles, and we just do a shortening and extension of shortening, along with that, the vital tendon weaving. So what are your views for that surgery?
So in our hands, that has been a very powerful technique. Very powerful, because like you said, it addresses everything in one go. What we have found is that the patient selection is very important. As a tool, it is very powerful, but in the context of where it fits in this situation, because of the natural history, I haven't gone for that as my first choice, mainly because we've spent a lot of time trying to understand what the child's needs are. We have gone down the soft tissue surgery route. That's not to say that people might not choose it. In some people's hands, that would work equally well. The shortening has an effect of both relatively lengthening the hamstrings or addressing the knee problem, but the shortening also weakens the quadriceps further. So the patella tendon shortening is then the bit that slows you down afterwards. So I could still do that at a later stage if the family and I felt that that was worthwhile doing. It's like something that I've got in the bank. Whereas if you do it in the first go and the child doesn't rehab well, then you're stuck because you actually haven't achieved the outcomes that you need to kind of achieve in the first instance. So it's a nuance thing for everyone.
And one more last question, sir. You said tenderness is surely not too much, but what about the foot deformity? The foot is going into valgus.
The hindfoot valgus is. We don't worry about it too much at the moment because if the foot is going into an AFO, the only question is whether an AFO would be comfortable or not. And most of the children in whom we have addressed the valgus, it is probably the last operation I do for them at skeletal maturity. Just before they leave the children's hospital, they want the valgus corrected. The only operation for that is a MTP fusion. With or without resection of the tibialis anterior, if you feel it's causing that dynamic supination.
As we were discussing that the soleus is the most important push-off power, and we are putting the child in an AFO. How long can we keep it in AFO and lose the push-off power, which is most important for the...
What is more important for her gain? Is it what the soleus will do, or whether...
the extension of the knee with gastro.
So what we're doing is harnessing the gastrocnemius for its effect on the knee and not worrying so much about the soleus, because the soleus works as a push-off muscle if and only if you have a good first rocker and you go down, and then the soleus has the ability to generate that eccentric contraction. Then it's a push-off muscle. But in her situation, she lands in foot flat with the soleus already long. So it does not have the ability to get that eccentric stretch which we get in mid stance, which is then what the soleus gives back in the push-off phase. She doesn't have it. So for me, it's too long anyway. It's not working well anyway. I'll use the orthotic as a substitute.
So can we all have some sound minds? So we have to harmoniously do it. The treatment of cerebral palsy has to be harmonious. What I'm going to do just for practice till the time the next presentation is on, I'm going to raise my hand and you have to clap with my hand going up. And my hand goes down, no one will clap. Okay? Can we do it all together? So all the claps for the family was here, so that we all could learn from the family and all the family were here.
Going to the next case, I would like to make it short and otherwise with delayed development, there are recognized tools. Otherwise, no other mental abnormality or visual impairment or behavioral disturbances. Coming to his muscles, you can see mainly adductor spasticity with knee flexor spasticity ranging from 3 to 2 and axis of 1 plus and plantar flexors 2. elevation, he is able to do e-walking and otherwise dealing with independent. Otherwise, he is half kneeling was in the maximum support and the squat to standing was in the maximum support, and he is coming up to FFC's grade 3. And he's having a contractor of both the hands.
So we can do that because they're going to do the examination anyhow.
So I'll just want me the video.
No, it's not the patient.
It's far better than any video. I've never seen it in my whole life.
Right. So the history we've got.
So what does the audience think? Is this GMFCS 2 or 3 now?
I'd go for it too.
You go for a 2. So how many of you feel that this gross motor function classification scale would be 2? The score is 2.
So why did you guys say 3? I mean, but that's okay. We will. So he's able to walk independently at his age. So that means as far downstairs, he may have some issues with uneven ground, and if he has to walk really far, he might want to use a stick. But the important things are that at his age, this is a very high level of function and very stable. So any problems that he gets are big problems because they compromise his independence. So for us as treating surgeons, the stakes are much higher if we identify a problem.
Secondly, at GMFCS 2, the difference between 2 and 3 is that he is more likely to be a community ambulator.
Absolutely.
Which is very, very important for his occupation and
Activities of daily living.
So Jayant, can we go through his clinical examination?
Just to fill in a little bit.
Yes.
He is a postgraduate geology student.
Fantastic.
And
Let's clap for that.
He's within the house. He's an independent ambulator, but for longer distances he uses a walker. So that is his functional status. And more than 50 meters, you are not able to manage independently.
And why is that? And why is that? Because of pain? You get tired. Where in your legs? In your knees or down? At the back, in the muscle itself? Okay. So that's again important to know in the history, is to say, if there is a change in the functional level, there has got to be some investigation as to why that occurs. So that would be important to find out.
Okay. So we've already been through the examination template. So I'll just quickly rush through it now.
Okay.
And then you just lie down like this.
My one request to all of you, we will go in a surgeon's style to tuck, discuss and finish a whole number of cases. Details of the surgery we have tomorrow also, totally dedicated for the surgical aspects, because very nicely other age group interesting cases are also there with us. So I request whatever is like a table tennis game, if the ball is thrown to you, tuck, you send back to us. Let's
last 5 overs left.
Okay, correct. That's right. Very nicely the discussion is going on. I would also like, when this examination is going on, one very interesting another finding for this case, that we thought that this spasticity is perhaps responsible for this kind of a gait and the tiredness or easy fatigability. We gave intrathecal baclofen and we found that his tone became so less that he deteriorated in his walking. So this is one of the way by which we decide whether the surgical relief surgeries, neurosurgical procedures to relieve spasticity will help or not when there is a global distribution of spasticity like spastic diplegia. So after giving the injection, we also give the injection by putting the intrathecal tube for 1 day dose, next day another dose, next day another dose. So when we have given the dose, we found that he deteriorated in his walking. So I rule it out that any kind of spasticity relieving neurosurgical procedures are going to be of great benefit is out. Now the question is, parents want that how best we can improve his gait so that he is much more community walker, and definitely at this age they want that cosmetically also he should look better from the next marriage point of view also. So let's have a discussion. So in existing motor function, how it can be improved and how the fatigability can be reduced. So what we do about our surgical procedures, that fatigability is another very important aspect which get reduced following the neurosurgical procedure. Either an ablative procedure selected